All right. Hello, my name is Jasmine. I am a student at California Career College. This presentation is for Dr. Garcia, who is the director of my nursing school. So I'm going to be covering obsessive compulsive disorder, body dysmorphic disorder, hoarding disorder, trichotillomania disorder, and excoriation disorder. So obsessive compulsive disorder is actually a subset of generalized anxiety disorders. It's characterized by unreasonable thoughts and fears, which are called obsessions that lead to compulsive behaviors that are called the rituals. So body dysmorphic disorder, hoarding disorder, trichotillomania, and excoriation disorder are actually considered forms of OCD. So these are all under the umbrella of generalized anxiety disorder, and the last three are on the obsessive compulsive spectrum, so to say, or so to speak. So I have this picture here to show you what somebody with obsessive compulsive disorder may be experiencing. And looking at this picture, you can kind of get a sense. I having a little bit of anxiety looking at it. There's a lot going on. There are a lot of heavy things here, like dysregulation, antipsychotics. So this is just to get a sense of what the overwhelming feelings that somebody might get with OCD. So the DSM describes it as somebody that must experience present or reoccurrent unwanted and intrusive thoughts. So repetitive behaviors and the obsessions. So obsessions and rituals, obsessions and compulsions. And they do this in order to relieve their anxiety. I put this photo here to show you kind of what somebody with body dysmorphia may look like. Normal. Everyone else sees this person as fit. This man is at the gym and he's lifting weights, but he may not see that. So going on to the definition, body dysmorphic disorder, it's when you can't stop thinking about perceived defects or flaws in your appearance. So a flaw may seem minor to other people, but you feel so embarrassed and ashamed that you may even avoid social situations. And at that point, it would call for professional help. Moving on to hoarding disorder, I put these two pictures here so that we could see the kind of perceived hoarding, what people perceive hoarding disorder to be, and the other forms of it. So on the right side, I have one that kind of shows an unsanitary condition, a cluttered condition, and that's kind of because it's been dramatized in the media with reality TV. On the left-hand side, you could see there are obviously no bottles of pee or rodents lying around. This person is actually extremely organized, but they're hoarders nonetheless. So the definition might help clarify a preconceived notion of it. So a person with hoarding disorder experiences distress at the thought of getting rid of items. So they will just excessively collect items, and the idea of throwing them away gives them a lot of grief. And that is at which point you just start collecting so many things that your conditions become unlivable. Moving on to trichotillomania, and I'm scratching my arm looking at this picture. Trichotillomania and excoriation disorder are obsessive compulsive disorders that involve pulling your hair, that's trichotillomania, and obsessively picking at your skin, which is excoriation. So I think everyone to some extent has the excoriation disorder. We all kind of bite our nails or pick at our little hangnails and stuff like that. But the definition of excoriation is to pick at the urge to pick at one's skin to the extent that either psychological or physical damage is caused. And the definition of trichotillomania is it's referred to as a hair pulling disorder that involves recurrent, irresistible urges to pull hair from the scalp, eyebrows, eyelids, and other areas of the body. So basically anywhere that you can pull hair from. And me being Persian, I have a lot of those places, so I'm glad I don't have this disorder, but it is obviously really unpleasant to be experiencing any of these things. So going on to an assessment for treatment, they're going to be screened, and they're going to be screened specifically to make sure that they don't have an anxiety disorder that's secondary to a medical condition or substance abuse. So we want to make sure that you have a generalized anxiety disorder, and that is your main diagnosis. And in order to do that, we have scales to measure all sorts of OCD disorders. So OCD itself, the Hoarding scale, generalized anxiety disorder, they measure the severity of your specific disorder. This is an example of an assessment that you might see. It involves the amount of time that you have been having the issue, the frequency of the issue, and the specific details regarding the issue that you have. And then you'll get a score or a number that indicates whether or not you really need treatment from a professional. So clinical features include, they're broken down behavioral, mood, and psychological. So for behavioral, you have agitation, compulsive hoarding, hypervigilance, impulsivity, meaningless repetition of words, repetitive movements. I feel like I'm doing that right now. Ritualistic behavior, social isolation, or persistent repetition of words or actions. So for the mood breakdown part of it, you're going to see people experiencing anxiety, apprehension, guilt, or panic attack. And for psychological, it's depression or fear, which I almost left out. Plan of care. To implement certain strategies and techniques for patients experiencing anxiety, we want to ask open-ended questions. We want to be a listening ear. We want to help identify anxiety by encouraging the patient to talk about their feelings and to explore behaviors that relieve the anxiety. That's what you want to do as a nurse. And so for the course of treatment, of course, that's going to involve some sort of counseling. Cognitive behavioral therapy has been shown to be very effective. Teamwork, collaborating to develop a multidisciplinary treatment plan that adheres to the safety of the patient and the team, and promotion of self-care activities. When you have these generalized anxiety disorders, and more specifically obsessive compulsive disorders, you tend to, when you're at the point that you need treatment, you tend to start neglecting yourself, personal hygiene, sleep, eating. Those things don't happen, and you become dysfunctional as a result. So 3 nursing diagnoses include ineffective coping, social isolation, and self-care deficit. Ineffective coping, you just can't handle the amount of stress that you're under. And for social isolation, obviously you are isolating yourself from maybe your spouse even. It's not just social situations, it could be your children. And that is a problem if you're a mother or somebody that has a job that they need to fulfill that includes dealing with people. Self-care deficit, that's the inability to meet all your nutritional needs, hygiene, sleep, to a point, if that goes on, a self-care deficit goes on and on, you become dysfunctional. It's just what will happen. So for pharmacological interventions, we have antidepressants, anti-anxiety drugs, other classes, and so the antidepressants, SSRIs, SNRIs, MAOIs, they're the first line of treatment. You have anti-anxiety drugs, which really kind of relieve the acute symptoms. They're used to treat somatic and psychological symptoms. And there are other classes like beta blockers, antihistamines, anticonvulsants, and antipsychotics. So considerations, obviously you want to consider suicidal ideation or suicidal thoughts with antidepressants since they have an association. Dependency, especially with the anti-anxiety drugs, you don't want somebody to get hooked on benzos. And for the other classes, you want to look at the way the beta blockers, the antipsychotics are the way that they are affecting them medically and physically. We all know that there are certain medical conditions that can happen from bad reactions to anything, but especially things like antipsychotics or like a blood pressure medication. So outcome identification, that includes, we want the patient monitoring their own anxiety levels. We want them using relaxation techniques to control their anxiety. We want them to identify their ineffective coping patterns, and we want them to seek assistance when they need it before it gets really bad. Increased confidence and self-worth, which can be hard if you have a disorder that is socially frowned upon. I mean, any sort of disorder, especially something like hoarding or trichotillomania, those things I can see having a real effect, as do all of them. But dealing with confidence, I could see being a huge issue, especially for those two things. And practicing self-restraint on compulsive behaviors. So we want them to kind of get control of their illness. For the evaluation part of this presentation, you want to evaluate the patient's improvement by asking questions like, is the patient experiencing less anxiety? Do they recognize their symptoms? Are they presenting with symptoms? Have they lessened? Can the patient cope with their level of anxiety? Can they perform self-care activities? Can they maintain social relationships and assume normal roles? So we've kind of been touching on that. And so for my closing statement, I want to emphasize the fact that we all, to some extent, go through anxiety on a daily basis, but there is a point where it becomes debilitating. And not only that, they become these very specific outlets that the brain goes to in order to relieve that anxiety, which would then become the obsession, followed by the compulsion, which is then done to relieve the anxiety. So it's kind of the OCD aspect of it is a way to treat yourself. It's a self-medication in a sense, a response to deal with the overwhelming anxiety that somebody feels. So I have this column on the side here, and I'm just going to read one or two. Everyday anxiety is like embarrassment or self-consciousness, an uncomfortable or awkward social situation. That happened to be the first one I picked, but obviously I feel awkward doing a video presentation. It gives me anxiety, but having an anxiety disorder is when you're avoiding social situations for fear of being judged or embarrassed or humiliated. So if I told you, Dr. Garcia, that I said I did not want to do this, I don't want to be on camera, then at that point it would be possibly an anxiety disorder, which he would probably then refer me to a doctor. So I'm glad I was able to do this. And let's look at the next one. Realistic fear of a dangerous object, place, or situation. So if I'm on the edge of a cliff, I, have every right to be very afraid of falling off of it. I will be cautious. If somebody nudges me, I would get really freaked out and tell them to back off. But if you are just standing on the sidewalk in a safe area and you don't want to be put on the street for whatever reason, that is the obsession. You can't put your foot on the street, and you get bumped into almost going off the curb onto a street. I mean, obviously there are cars, but let's just say it's a quiet neighborhood or something. At that point, if you had a huge meltdown due to touching the street, then it would be considered an anxiety disorder. So anxiety, it's not exactly something that you can go in and get a blood test for. It's all based on assessments, but there are very clear-cut ways to identify whether or not you have an anxiety disorder and whether or not it is on the obsessive-compulsive spectrum or not. So, so thank you for listening, and I hope I can edit this Zoom video because I am lagging here. But if not, stop here.